Welcome back to the Ninja Nerd Podcast. Today we have a brand new episode on testicular cancer. We're moving through oncology. We've been really plowing through oncology here. It's been going pretty well.
Yeah, I mean, we've got brain, breast. Now we're down to the beads.
To the beads. There's beads, sister.
His hairy stinking beads.
That's a Rush Hour reference for anyone that cares.
Yeah, hopefully you know
Chris
that.
Tucker.
Yep.
But hey, serious note, we're talking about testicular cancer, one of the most common malignancies for men.
Yeah.
And something that should definitely be talked about and will be talked about.
Yep.
Let's get right into it.
Let's talk.
2 cases, right?
Yeah, it should be two. 2-1.
2 cases. Let's do it.
Yeah, let's do it.
All right, case 1. We have a 32-year-old man, no past medical history, notices a firm, painless lump on his right testicle while he was showering. There's no trauma, no gynecomastia, no systemic symptoms at all. So, Zach, what do you think with this? I mean, of course, it's obvious what you think, right?
Yeah.
It's a stupid question, but it's like still...
But reason through it.
Yeah, reason through it. Obviously, you hear someone with a painless lump on their testicle, yeah, it's pretty alarming. But
Yeah.
I know it's not only just testicular cancer. There's other things, but of course, that's where our minds go.
I mean, you're kind of like off to like a good start in the sense that if we have a painless testicular mass, you obviously have a lot of things in your differential. Usually things like hydrocele is a common one, varicocele is another one, spermatocele, you can get those. Usually things like epidemiolitis or testicular torsion, those are usually more painful. So that's going to be pretty easy to say that's unlikely. But I still think like at this point, you can definitely consider malignant. That's why always whenever you have that, get a scrotal ultrasound. Okay. And that's going to give a lot of information, at least to say, okay, this definitely looks like it's more hydrocele, more spermatocele, more varicocele. Hey, this is like a more of a hypoechoic mass. It looks like it's a little bit more solid, and that could be suggestive of cancer. So I would definitely say get a scrotal ultrasound. So tumor markers would be another one that I would order. The only reason I would even consider that is based upon the scrotal ultrasound itself. So if I got the scrotal ultrasound, it didn't show like a hydrocele look, it didn't show like a varicocele, it didn't show like a spermatocele, it showed something that was suspicious for a malignancy, that's when I would get tumor markers. And the reason why is it can help a little bit. And it's mainly adding utility to, especially in your clinical vignettes, to talk about the possibility of which type of tumor it is. Is it a germ cell, a non-germ cell? If it is a non-germ cell, which one it is it, if it's a germ cell tumor, is it a seminoma, a non-seminoma? So those are things that I would order. And so those tumor markers are usually going to be primarily like β-hCG, AFP. I wouldn't say we often order, it's called placental alkaline phosphatase or PLAP. You can do that. They bring it up on the exams, but we don't really routinely order that one. The one that we do, I would say, in place of that is LDH, but LDH doesn't point to a specific type. It's mainly beta-hCG and AFP. LDH, those are the 3, but beta-hCG and AFP will be the most helpful for your exams.
Well, let me start you off with the ultrasound and show you what we got.
All right.
So for our patient, we perform an ultrasound, and we determine a homogeneous, hypoechoic 2.8 centimeter intratesticular lesion. No cysts or calcifications. So what does that tell you? I
mean, it definitely tells me about potentially like cancer. I mean, there's different types. And so here's the other thing. This patient is
32.
32. Okay. So usually anything greater than or equal to 30 makes me think seminoma. Seminoma is the most common testicular tumor when it comes to it, especially over the age or equal to the age of 30. And so that's what I'm thinking right off the get-go, given their age, given the overall look. But I think the tumor markers may add a little bit more to help me out.
Okay, well, we have an AFP, beta-hCG, and LDH.
Okay.
And I'm also going to go ahead and just state the norms for people who are watching.
All right.
So for the AFP, we get that result back, and it was 4. Normal is less than 10.
All right.
Beta-hCG is 12. Normal is less than 5.
So just a little bit.
A little bit high. And our LDH is 260. Normal is 100 to 190.
Just a little bit.
What's that interpretation? What is that telling you?
All right. So LDH, again, that's not every like specific as well. It kind of just tells me there's a little bit of turnover, cell turnover. And so you could see that really in all of them. It could be sometimes normal and it doesn't really help. But beta-hCG being minimally elevated and AFP being normal makes me think a little bit possibly likely a seminoma. Again, seminomas, one of the big things about them is that they have a very mildly elevated beta-hCG. It's very minimal, usually a normal AFP. And that's what I'm thinking about at this point.
So you've talked about a seminoma, and that's fine. But when we're talking about seminoma versus a non-seminoma, just so we kind of understand, what are the other types, if you can lay them out for us?
Yeah, nonseminoma is usually going to be an embryonal carcinoma. I'd say that's not like super common, but it's usually if you get like a orchiectomy and you look at it under pathology, it's like a hemorrhagic kind of necrosis and a lot of apoptotic bodies that are present. Usually that one's possible. It may have a little bit of elevated β-hCG. Usually AFP is normal for that one as well, unless it's mixed with another kind of tumor. But then there's teratomas. Teratomas are like Frankenstein tumors. They're like tumors that got a bunch of different tissues in. I'm not kidding. It can have bones, it can have teeth, it can have hair, it can have muscle, it can have cartilage. And so that's another one. Another one is called yolk sac tumor, so it's actually derived from like primitive yolk sac tissue, which is in the embryo. And that one usually has a very elevated AFP level. So that would make me think about a yolk sac tumor if I had like a super high AFP level. Choriocarcinoma looks like placental tissue. I'm not even kidding. It looks like placental tissue. It's like syncytiotrophoblasts and cytotrophoblast tissue that pump out lots of β-hCG. So β-hCG levels that are super, super high would make me think like choriocarcinoma. So that's our non-seminoma types.
But for our patient, we are thinking most likely a classic seminoma.
Yeah, I think it's definitely more likely seminoma. Now, they have a elevated beta-hCG. They're greater than or equal to 30, which makes me think, again, that's more common for seminomas. You could still say, like, could it be an embryonal? It's possible, but embryonal carcinomas don't make up a large proportion of, like, testicular cancer. So I'd say, yeah, I feel pretty good that it's probably going to be a seminoma.
And if we're doing the radical orchiectomy, you have to do that in order to obviously get pathology.
Yeah, it's kind of nice with this because, I mean, it's not great, but, you know, removing a testicle is never fun. But at least in this, you get like almost like curative result, which is beautiful. But it also helps you to determine the type, which may guide a little bit more of your treatment. So when you do a radical inguinal orchiectomy, you're removing like, you know, the testicle, the epididymis, you're removing a lot of the spermatic cord, stuff like that. So you're removing a lot of different like vital tissue here, but you're most importantly removing the tumor so that it actually can't grow or spread. So that's definitely something I would do, and I would definitely probably even do that before doing like staging.
I was going to ask you, so you wouldn't do any CT yet?
No, I don't think, because no matter what, you're going to have to do it. You're going to have to remove the testicle no matter what. So doing a radical orchiectomy, whether it's metastatic or not, is still going to be an option.
Gotcha. Okay.
Yeah.
Well, hey, we do the post-orchiectomy pathology.
Okay.
It comes back as a pure seminoma, no vascular invasion.
Oh, that's good. That's pretty good, actually. That probably means that in this case, seminomas don't usually like metastasize. If they do, it's very local. So they usually go to like nearby lymph nodes. So they may go to like the retroperitoneal lymph nodes if they do potentially invade there. But, you know, only way that you could really see that is getting a CT scan. So I'd have to stage them a little bit. But usually the pathology, that's pretty good. It tells me that it's at least like for right now, it seems like it's local. But I'm going to go ahead and get a CT scan. I'd probably do like chest just to make sure, because choriocarcinomas, those usually go to the lungs. But this is a seminoma, so I probably wouldn't need it, but I would probably do it just in case. Abdomen, pelvis, that's the main one. Abdomen, pelvis, CT scan is going to be the big one, because I want to see if it's spread to the nodes. So that'd be the big one I would do.
All right. Well, we do a CT scan. It's clean. Nothing wrong.
All right.
Good to go.
So this is definitely one of those kinds of cases where if you got a seminoma like this, I'd say it's like, you know, you can do stages, but I like to just consider like low risk, high risk kind of patients. So I would consider this more of like a lower risk seminoma, or like a less advanced stage, like a lower stage like a seminoma. So radical inguinal orchiectomy is probably good enough for this patient, and I can just like do some active surveillance by trending the tumor markers and just making sure those are okay. I could even potentially do like a repeat CT scan if I need to make sure that nothing else has kind of recurred. But that's probably the good way to go. You don't have to do much else. If it was like, it was a little bit more high-grade dysplasia, if there was some lymph node involvement, then I may go to doing what's called radiation therapy. Because these tumors, seminomas, that's a classic term for your step 1 or your step 2, they're radiosensitive. So that means that they respond very, very well to radiation therapy. So that's something I would consider, but I would only really be doing it if it was something that like they had some node involvement, because we can maybe get some benefit with that radiation therapy.
Well, what happens if he can't comply with intensive follow-up?
Then I would do the radiation therapy.
Okay.
Yeah.
Okay.
If you don't stick with that, I would suggest radiation therapy just to make sure. Yeah.
All right. Well, that does it for case 1. Pretty straightforward. Good prognosis.
Yeah.
And overall, I mean, testicular cancer does have a favorable prognosis.
Overall, in general, it is a pretty good prognosis, especially seminomas.
All right. Well, case 2.
All right,
We have a 25-year-old man with a 3-week history of rapidly enlarging left testicle, mild shortness of breath, and new bilateral breast tenderness. Well, what are you thinking here? There's some pretty big red flags here.
Well, I think he's got testicular cancer. No, we know that there's something obviously is leading us in that direction. But the question is like, okay, how do we like think about this, right? So, gynecomastia seems to be the case. Bilateral gynecomastia, which that sucks. Mild shortness of breath. Maybe some lung involvement.
That would scare me if I hear that. That's concerning.
Yeah, dyspnea definitely could be concerning because, like, they're always like non-specific symptoms like metastasis, like cough, dyspnea, maybe hemoptysis if you really want to be scary, but it's not usually super helpful. But rapidly enlarging left testicle with mild shortness of breath and new bilateral breast tenderness kind of makes me concerned for like choriocarcinoma. And the only reason why is that choriocarcinoma, it's very, very aggressive. It grows quickly and metastasizes quickly. And so you would see, and it also happens, nonseminomas are common in males less than 30.
Okay.
So this probably is a nonseminoma, is my guess. And then it's aggressive. That makes me think choriocarcinoma. The most common location for choriocarcinomas to go, the lungs. They usually get bilateral, they call it cannonball metastasis. So I think they got gyno, probably from a lot of beta-hCG. I think they probably got some pulmonary metastasis causing the shortness of breath. But either way, I'm going to do the same thing. I'm just going to get an ultrasound and get some tumor markers. Theoretically, if this is a choriocarcinoma, it'll show like a mass that is concerning, but the beta-hCG will be through the roof, theoretically.
Okay. All right. Well, hey, we do that. We get an ultrasound. We have some markers to follow. For the ultrasound, it reveals a heterogeneous mass with cystic and hemorrhagic areas.
Okay.
What does that say?
Usually that's nonseminoma. So usually like seminomas, they don't usually have that kind of pattern. Nonseminomas, they can look a lot of different ways. Like for example, embryonic carcinomas can have this kind of appearance. Yolk sac tumors don't usually have, well, actually, yolk sac tumors can have a lot of like vascularity to them. So they can have like Schiller-Duvall bodies and stuff like that. But choriocarcinomas have a good amount of like vascular tissue and placental tissue. So yeah, either way, I think this is non-seminoma pattern, but I'm still going to wait for those markers.
I got them. I got you. AFP is 6. Normal range is less than 10. Beta-hCG is 105,000.
Jeez, I don't mean to laugh, but like that's crazy high. So that kind of tells us a lot already. But
normal range is less than 5.
Yeah,
you overshot it there.
Yeah.
LDH is 680, and again, normal is 100 to 190.
Yeah, and so that's a tumor burden. Heavy cell turnover. The more cell turnover, the more the LDH. AFP screams more yolk sac tumor. Beta-hCG screams more choriocarcinoma. So I definitely think that's explaining everything. And usually with gynecomastia, the reason why that actually develops in these males is because beta-hCG, it kind of acts like luteinizing hormone. And luteinizing hormone stimulates Leydig cells to make testosterone. Testosterone in a male, whenever you have too much of it, like abruptly, it gets aromatized. Yeah, by aromatase. And that makes estrogen. And estrogen, unfortunately, in higher levels in males can cause some feminization, which is going to result in them getting some moobs. So that's yeah. And then I definitely think the shortness of breath is probably some lung met. So we should definitely follow up with some chest CTs if that comes up. But yeah, that's what I would think from this one. But either way, I gotta do the same thing that we did with the seminoma.
I was going to say, no matter what, it's going to be the same exact process. We did ultrasound, we got the tumor markers, and guess what? Now we're going to have to do the radical inguinal orchiectomy,
right?
And then get patho.
Snip. Yep,
exactly. Clip them. So for pathology, we have a pure choriocarcinoma, extensive syncytia trophoblast. Boy, does this bring me back to embryo.
Oh, let's get away from embryo. No.
I'm just thinking embryo again.
Yeah, I mean, it's placental tissue, similar to placental tissue. So definitely. Yep.
That's crazy. So now we have the pathology. We performed the orchiectomy. We have to stage. So I would think actually first you want to get a CT and say, has this metastasized? Which looks like it has. Yeah,
that's what I would do. I definitely would focus on the chest, but I would even go with the abdomen and the pelvis just to make sure it didn't go anywhere else. Because they can go other places. Usually it's not too common they go to the liver, but they can. They definitely can go, I want to say another area is the bones, but the brain is a really big one too.
Okay, so far with that choriocarcinoma, lungs and brain.
Yeah, lungs and brain would be the big ones. You can get some bone involvement. But yeah, the first, and then you can, obviously they spread to nodes. So any kind of retroperitoneal node involvement, you can probably pick up from the abdomen and pelvis, but the chest is going to be the big one. But yeah, chorio loves the brain and it loves the lungs. So those would be the areas that I'm really going to be kind of focusing in on.
So for the CT, we have numerous bilateral pulmonary nodules, retroperitoneal nodes that are 3 centimeters, and the brain MRI is negative.
Oh, they got that going for them. But either way, it's metastatic, unfortunately. So this is a pretty significant, and then that's often what happens with choriocarcinomas. They're pretty aggressive. You know, like when you think about the nonseminomas, like embryonic carcinoma isn't great, but it's not as aggressive as this. Yolk sac tumors, they're malignant, but they're not like super aggressive, and they don't usually metastasize like this. Teratomas, unless it's in a adult, those can be a little bit more malignant, but if they're in children, they're actually pretty much benign. You don't know anything about them. So, but yeah, in this case, this is definitely metastatic. Either way, we already did it. We did the radical inguinal orchiectomy. These patients don't do well with radiation therapy.
So chemotherapy then.
Chemotherapy would be a good one. I'd probably do my best to see if that can shrink down some of these like areas, and then especially some of the nodes, and see if I can get those nodes a little bit smaller, the retroperitoneal nodes. And then from there, we may try some, you can do like lymph node. You can do retroperitoneal lymph node like dissections.
Okay.
So that's something I would consider if I really, really needed to, is I would definitely get them systemic chemotherapy, because that's going to be the only thing that's really going to help with the degree of metastasis. And that may help to shrink these nodes a little bit. But then afterwards, I would see if I got that node down a little bit more, and I would do a radical, what's called retroperitoneal lymph node dissection.
Anything else for case 2?
The only other thing I would say is just make sure that you're monitoring, your tumor markers. Because if, for example, if I did this, let's say that it wasn't metastatic. All right, so let's say that they didn't have any involvement of the lungs and any other kind of like nodes. In those situations where you just have like a choriocarcinoma just in the testicle, just that's it, you do the radical inguinal orchiectomy, and you can go straight and remove the retroperitoneal lymph nodes if you want to prevent it kind of from spreading. But again, I would just say in this particular situation, I'm pretty happy with what we did. We removed the source of the tumor. We're doing chemo for the degree of metastasis, and considering, this kind of like retroperitoneal lymph node dissection if the nodes get smaller.
All right. Well, there was 2 cases for you. Pretty straightforward. First case, favorable outcome, good prognosis. Second case, it's less than ideal, but hey, we have the run through. We know what we have to do now. Yeah. And I think now we're just left with Zach. If we can do a quick recap, maybe a 60-second recap on what we've talked about. I'm going to time them too.
I'm not gonna make it.
I'm going to definitely time you now. 60-second recap. Let's see what you got here.
All right, I'd say the big thing is like seminomas. You want to remember with these that they're the most common tumor in males greater than or equal to 30. Non-seminomas are more common in those less than 30. With seminomas, radiosensitive is the big exam pearl. They probably have a little bit of an elevated beta-hCG, but their AFP is going to be normal. Non-seminomas are going to be usually something where the 2 important ones is choriocarcinoma, think elevated beta-hCG. Spreads to the lungs, spreads to the brain. Very aggressive. Yolk sac tumors, usually those are going to be having a super elevated AFP. The thing is that regardless of the type of tumor, you're going to be doing a radical inguinal orchiectomy. You should do this for pathology results, removing the source, and then proceed to staging. Never biopsy because you can seed the tumor. From there, I would say my decision afterwards, after the radical inguinal orchiectomy, depends upon the degree of the disease. So if it's a seminoma, oftentimes if it hasn't really gotten like that bad and gone to nodes or metastasized, I can probably just survey. If not, I can offer up radiation therapy. For the non-seminomatous kind of tumors, usually that's going to involve pretty much chemotherapy, and we can consider removing some of those retroperitoneal lymph nodes. But overall, these can have a decent prognosis.
I feel like especially with the younger age, with our first patient, 32, I feel like even trying to survey that, it's like, well, hey, you're 32. Let's be a little bit more aggressive here. Yeah. Maybe you might want to do the radiation therapy.
Yeah, it's definitely always an option. Yeah. And some people will actually want to go that route just for the safety aspect of it. If they, more reassurance, I guess.
Yeah. I think that would probably be my thing is like, hey, I want to be like really, really sure.
Yeah. With everything comes risk, but sometimes reassurance is, it says it all for you.
Yeah, it really does. Peace of mind.
Yeah.
All right. Well, that's all I had.
Yeah, man. So I think overall, just always think, what do the tumor markers tell me? After that, consider orchiectomy, stage them, and then tailor the treatment depending upon that stage. I think that can give you everything you guys need to know. But man, I think this was a good one. I really hope that you guys liked it. I hope you enjoyed it. I hope you learned a lot. And man, engineers, I just love you guys. You guys are awesome. So thank you, love you, and as always, till next time.